So we're starting with a question. Not a histological feature of lichen planus is acanthosis, hyperkeratosis, neutrophils in stratum corneum, or pigment incontinence. Looking at the histopathology of lichen planus, right on top you can see in the epidermis there is hyperkeratosis. So the first point is epidermal hyperkeratosis. Coming down lower in the epidermis, in the stratum granulosum, so you have a hypergranulosis, that means an increase in the thickness of stratum granulosum, which is wedge-shaped. Lower down, there is sawtoothing of the rete ridges. So the rete ridges are at the interface between the epidermis and the dermis. Okay? At the basal layer, there's vacuolar degeneration seen in the keratinocytes. Individual cells would have vacuolar degeneration. These are known as civet bodies. That means individual cells get necrosed. At the dermoepidermal junction, that means between the epidermis and the dermis, there is a band-like infiltrate of lymphocytes, the bluish band which you can see. These are there, so that's in the superficial dermis. And this is called a lichenoid infiltrate. This is characteristic of lichen planus and other lichenoid skin conditions. This band-like infiltrate of lymphocytes, because they're basophilic, so it's called a lichenoid infiltrate. Incontinence of melanin is also a point in lichen planus. So that means when the lesion heals, when lichen planus heals, there are melanocytes, or melanin drops down into the dermis. So that's called incontinence of melanin. Melanocytes, as we know, are in the basal layer of the epidermis, and because of the inflammation, during the healing process, it drops down, some melanin drops into the dermis. That's called incontinence of melanin. So taking a closer look, the uppermost arrow here shows the wedge-shaped hypergranulosis, right, like an inverted pyramid. Lower down, you can see individual basal keratinocytes are getting necrosed. Okay, so that's vacuolar degeneration. You can see a little sawtoothing of the rete ridges, and I've pointed out some lymphocytes there, the part of the lichenoid infiltrate at the dermoepidermal junction. So the answer to this question, we have acanthosis. Acanthosis means thickening of the epidermis, right? Hyperkeratosis is there. Neutrophils in stratum corneum are not seen in lichen planus. This is a feature of psoriasis. Okay, these are specifically known as Monroe's microabscesses, a collection of neutrophils in the stratum corneum. So this is the answer. And pigment incontinence is seen in lichen planus, as explained. So lichen planus is a T-cell mediated autoimmune disorder. It's characterized by 4 Ps. So they're violaceous or purple, flat-topped papules and plaques. That means elevated lesions, right? And these are classically pruritic. Lichen planus affects the skin, the mucosa, hair, and the nail as well. So on the skin, you can see these characteristic lesions. You see the flat top plaques, which are purplish, okay, and they're polygonal as well. These occur typically on the wrist flexors. They can occur on the trunk, on the shins also. Kebner phenomenon is positive. I'll talk about that in a while, okay. And there's a specific type of lichen planus. It's called lichen planus pigmentosus. In this type, there are flat patches of pigmentation. And these are not so much purple, but they're more ashy gray pigmentation. This usually covers the face and the neck. So that's one particular type of lichen planus pigmentosis. On the mucosa, you classically see Wickham's striae. This is usually seen on the buccal mucosa, and Wickham's striae is basically lacy whitish pattern on the buccal mucosa. You can also see violaceous plaques of lichen planus sometimes. Patients may have a burning sensation in the mouth. Okay, that is one symptom of oral lichen planus. In the hair, I'll show you a picture of lichen planus affecting the scalp. You will have scarring alopecia and perifollicular pigmentation classically. In the nails, you can see here, classically you have a pterygium of the nail in lichen planus, which is seen here. This is also known as pop tenting, okay, where both the parts of the nail are elevated towards the center, towards the middle. This is scalp lichen planus. So it is a scarring type of alopecia. That's important. Okay. There is central atrophy in this patch, and around in the borders you have the activity of the lesion. So you can see there is perifollicular hyperkeratosis, and if you take a closer look, when you look with a dermatoscope or a magnifying glass, you will see perifollicular pigmentation. That means pigmentation around the hair follicles, which will also be violaceous. So Kebner phenomenon is also known as isomorphic response. It's the appearance of new skin lesions of a pre-existing skin disorder on areas which are injured, okay, in otherwise healthy skin. So this is classically seen in 3 conditions: psoriasis, lichen planus, and vitiligo. So you'll see, like here, you can see the small erythematous papules seem to extend along a line. So if the person has sustained trauma, like a scratch or even some insect bites, those lesions come onto those new spots as well. So the treatment of lichen planus is simple. Divide these things into topical treatments and systemic treatments. In topical, we usually use systemic topical corticosteroids. Salicylic acid ointment also helps in lesions that are thick, that are keratotic. So sometimes we combine corticosteroid with salicylic acid ointment. Tacrolimus is a common calcineurin inhibitor, which we use topically as well. Okay, we can use that for oral lichen planus. Systemic medications can be oral retinoids like acitretin or corticosteroids, which are given usually in an extensive lichen planus or one which is spreading rapidly. So next question, cicatrizing alopecia, that means scarring alopecia, with perifollicular blue-gray patches is most commonly associated with erythematous scaly plaques, whitish lacy lesions on buccal mucosa, arthritis, and discoid plaques on the face. So the answer would be the Wickham's triad, which they're talking about, of lichen planus. So they've described scarring alopecia in lichen planus, right? And that is associated with the buccal mucosa lesions, again, of lichen planus. The option A, erythematous scaly plaques, is typical of psoriasis. Option B again would indicate psoriasis because psoriasis is associated with arthritis commonly. Option D is discoid plaques on the face. This typically suggests DLE, that is discoid lupus erythematosus. Okay, so these are not the answers. In which of the following is Kebner phenomenon not seen? Lichen planus, psoriasis, lichen nitidus, or lichen simplex chronicus? So we know it's seen in lichen planus, psoriasis. Lichen nitidus is a condition in which you have follicular papules classically seen in children. You may see it on the trunk, on the elbows and knees, on the buttocks as well. There's no specific cause for why it occurs. Lichen simplex chronicus also means eczema. It's just a well-circumscribed discoid eczema. Okay, so the answer is lichen simplex chronicus because eczema does not follow a Kebner phenomenon. This is just a photo of a discoid eczema, okay? And this is lichen nitidus, which is pinpoint papules, shiny papules, okay? This is seen on the knees and elbows here. Wickham's triad is seen in lichen nitidus, lichenoid eruptions, lichen striatus, or lichen planus. This is easy. Itchy polygonal violaceous papules are seen in. The answer is clearly now lichen planus. Okay. Psoriasis, you see scaly erythematous plaques. Pemphigus is a bullous disorder. You will see flaccid blisters or on an erythematous base, on a reddish base. Okay, there's inflammation. And in pityriasis rosea, you will see annular scaly plaques. The most characteristic finding in lichen planus is civet bodies, basal cell degeneration, thinning of the nail plate, or violaceous lesions. So civet body is the necrosis of individual keratinocytes in the basal layer, right? That's not very characteristic of just lichen planus. It can vacuolar degeneration can happen in other lichenoid conditions also. Basal cell degeneration is quite characteristic. of lichen planus and lichenoid conditions as well. Thinning of the nail plate is not seen exclusively in lichen planus. Violaceous lesions indicate lichen planus but can be seen in many other conditions as well. Okay, you may have erythema multiforme, which may look violaceous on dark skin type. So that's not classical. Basal cell degeneration would be the best answer in this case. Treatment of choice for acute generalized lichen planus. So we're talking about some oral treatment. So topical corticosteroid, again, difficult to apply on such a large body surface area. Systemic corticosteroids can control. Antihistaminics are just symptomatic treatment. Emollients, again, are just symptomatic improvement. So systemic corticosteroids would be the best answer here. Okay. Characteristic nail finding in lichen planus is pitting, pterygium, Bose lines, or hyperpigmentation of the nail. Pitting is classical of psoriasis. Pterygium is classical of lichen planus. Bose lines are lines which indicate a particular time when a patient has gone through stress or severe illness or malnutrition. Okay, so they are lines that occur at the same distance from the nail fold, and they occur on all the nails, all 10 nails. Okay. Hyperpigmentation of the nail plate is seen in many conditions, not specific to lichen planus. Interface dermatitis is histological feature of psoriasis, lichen planus, pityriasis rosea, or dermatophytosis. Interface dermatitis, or the lichenoid infiltrate in the superficial dermis, is seen in lichen planus.